hope everybody can hear me. Hello and welcome to the Co-Diagnostics User Meeting 2025. We are glad you can make the time to join us, and we look forward to a productive round of lectures and workshops. I'm Stephanie, your host for this evening, or morning or night, depending on your time zone. A few pointers before we start. Each lecture will be 60 minutes long, with an additional 30 minutes reserved for any questions afterwards. If you would like to ask a question, please open the question box in the upper right corner and type out your question. Our support experts, Benjamin and John, will do their best to answer your questions, and the speakers will also answer questions after the lecture. All right, now on to our first speaker. Please welcome Dr. Nick FAHEY. Nick. Are you there? There you are. We can hear you now, and I will give you permission to share.
Right. Well, thanks very much for the invitation to present to the user meeting. The last time I did one of these, it was actually a physical meeting, so that's how long ago that was. My name's Nick FAHEY. I'm a New Zealander, but I'm living in the UK. I've got what we call the alphabet soup, which is the combination of letters there, which allows me to be a specialist in prosthodontics in the UK. And my day-to-day practice is just prosthodontics and mainly fixed prosthodontics and implant dentistry. I'm the co-director of a teaching academy. I also own a practice, and I'm an author. So probably the nuts and bolts of why you might be interested in what I've got to say is I've been heavily involved with guided surgery for at least 25 years, and I've got over 32,000 cases with over 5,000 implants placed using a guide. And I don't mean like pilot guides. I'm saying placing the implants through the guides. The great man used to say no one should have to die with their teeth in a glass of water beside their bed. I would make the argument that patients these days don't have to live with poorly positioned implants. And whilst a lot of dentists in the UK just want to place a great number of implants, I'm more passionate about placing great implants. I come from New Zealand, which is basically the other side of the world, the home of the mighty Maoris. The once mighty All Blacks. We're not quite as good as we used to be, but we're still good at sailing. And this is where I come from, Canterbury, which is down in what we call the mainland, the South Island. And Canterbury's probably best known more recently, and interestingly about the same time I started using co-diagnostics. In 2010 and 2011, there were two quite major earthquakes, which just destroyed the city. It's Lord of the Rings land, and if you're into hunting, fishing, shooting, any sort of outdoor pursuits, then New Zealand's really a great destination either to visit or live in. And I thought, seeing there might be quite a few Europeans here, I'd just overlay New Zealand over Europe, because a lot of people perceive that New Zealand's quite a small country, but you can see from this map that it's a substantial piece of real estate. I run a practice with my wife, who's a dentist, and we're in England, and we're just outside of London in a place called Reading. I know Snappy's been, and not that far from Heathrow. I used to work in Harley Street, and then after a while, I decided to extend the practice, and we've did it pretty sympathetically, and we've moved very, very digital. We're already very digital, but we're harnessing and using the tools that are available for us in dentistry every day. And the nice thing about it is there's never been a more exciting time to be in implant dentistry, in my opinion. We live in a beautiful part of the world. It's probably one of the reasons why I'm still here. And I live 5 minutes away from where I practice. With regards to the book was not a labor of love. It was just labor. It was really only written because of COVID. Somebody offered me the opportunity to write a book. And at that time, practices were closed, etc. So it seemed like a good idea. And although it was painful doing it, it's really opened a lot of interesting doors for me, and met some cool people through lecturing, and done some pretty cool things and lectured in some fairly neat places. And it became pretty obvious that there was a bit of a lack of a space for education and guided surgery. So we run a proper guided surgery course. And what I mean by that is it's not just one day trying to teach you everything about guided. It's a 3-part, 2-day course, so 6 days in completion. So really nose to tail, from the most simple stuff to do with guided surgery through to the most complex. It's only reasonable there's a bit of a disclosure, like I have been in the past paid to speak. In fact, I'm getting an honorarium for speaking today. But the one thing I'd like to mention is everything that I show is stuff I use in my practice because I believe in it. And a great example of that would be I'm a KOL for both Swiss Meter and Nematech. But you'll be able to see I still use a lot of co-diagnostics in my daily practice. And, that's, like everybody else, I'm paying for it. So it's not something I'm getting for free. So what have the last 25 years taught me? This presentation in the next 60 minutes, I'm going to hopefully cover some tips and tricks for everybody. I've tried to do a bit of both. So there's some quite detailed planning in there with some videos, and then likewise some clinical stuff for the people the clinicians who might be looking, who are more interested in that. Guided workflows have massively streamlined the way I do my dentistry and improved patient outcomes, but also the patient treatment times. So we're going to spend a reasonable amount of time looking at that. And one of the massive advantages with guided surgery that so few people seem to leverage, or certainly in the UK, is that guided surgery and immediacy are perfect partners. So let's dive into the presentation and charge up our knowledge on all things to do with our guided game. When I first presented this at the user meeting in it was Berlin, the lecture of the thing was Time to Leave the Stone Age, and it was a bit of a reference about obviously dentistry being done in very old ways, but it was also a reflection on taking impressions. And here's a friend of mine nearly killing a patient trying to take an LJ. And I've decided long ago that I don't want my dentistry to live in this near analog world when it can be very much more digital. And when we've got all of these fantastic tools that we can use to just make our treatment so much more predictable in the patient journey, easier, but at the same time protect ourselves, I think we've got to ask ourselves questions when we're clinging to the old ways. And I know this because my journey started way back in the day, the end of the 90s, when I was at the hospital. And if you had the temerity to ask for a 3D image, this is what you got. This is a thing called a scanora. And it's not really what we would call a 3D X-ray nowadays, but it gave you a sagittal slice, so you could see some reasonable anatomy. And if you were bonkers enough to ask for a CT scan, because that's what they were in those days, a CT scan, you're almost laughed out of the department. So one of the reasons that I was quite keen on getting into implants is because I was having all of these oral surgeons place the implants in bad positions for me, And I was thinking, well, I could probably do that myself. So we were taking these 3D images and we're doing all the planning, but we're still getting results like this. You know, the screw holes are fine on this side, but then we've got a screw here slam in the embrasure, and then for good measure, another one as well. Not too bad on this side. And as you can see, we've even got like a cantilevered wisdom tooth. This patient wanted more teeth. The things that we've learnt along the way, eh? So things that we didn't really understand, we were lifting these huge flaps. We were going bone supported. We had implant systems that wouldn't allow us to place the implants through the guide. And we're sending out a lot of stuff so that we're having the CBCTs taken outside by a third party and various things. So we didn't know what we didn't know. And even though guided surgery had so much promise and was sort of under delivering, you know, I still stuck at it because I just thought, you know, it's so close to, you know, being something that I could use in my daily practice and would make such a huge difference. And then we had that unpronounceable Icelandic volcano explode, and that meant that I spent a few extra days in Geneva after an ITI symposium. And at the end of that, I took them into lending me an iTero, and I didn't really know what to do with it because in those days, the iTero, you couldn't even use it for taking an impression, or sorry, like an impression of an implant. So what we started doing is taking impressions of the teeth before we do the treatment. And, you know, I don't know if other people were doing this, but we were certainly the first people to do it with Simplant. And, you know, lo and behold, that's the way everything's done now. So here we are. This is a Simplant case done a long time ago, 2010, I think. And we've got a cast that's even been superimposed because we've been able to match the scan up. Then we've got the stereolithic guide that's been made. Immediate loading, end of 2010, this case. So we still been doing immediate loading for a long time. And interesting, you can see the plan or the guide only supported 4 implants. So I freehanded one of the implants, even though, you know, I'm not as, probably nowadays, I'm not as worried about primary stability. So I probably wouldn't do that. And this is the final result. It's a hybrid, and that was finished in 2011, and that's still going strong. And this was the patient the last time I reviewed her, probably the most pleased with the denture out of everything. You know, if we were to do the hybrid, we'd do it completely differently again. Although the nice thing is I think I can probably redo that case as an FP 1.5, or certainly an FP2. And that was in 22. So I know this case is doing well. So, you know, even then guided surgery is allowing us to put the implants in the right place and get good results for the patients. But it was difficult to justify for single cases, single teeth, because of the extra cost and the large amounts of radiation. And this is a case I don't even have the surgical pictures because it was so traumatic, and she was so nervous she couldn't have sedation. You know, get that. No angle screw corrections in those days, so technician gets us out of trouble with a nice crown. And this patient, I've not seen her again, but I do see her in the village, so I'm sure she would have told me if things weren't going well. And although I don't agree with everything Lindvicius says, I do agree that, you know, the 3-dimensional implant positioning is vitally important for long-term outcomes for patients. You'll sometimes see a really poorly placed implant do okay, but the majority of the times when you see patients who have implants that are in trouble, they're malpositioned. When I started talking about guided surgery, people just used to say that I just probably wasn't very good. And that's possibly true. And yes, I can probably live with that. But I've also been about working smarter, not harder. And I've seen a lot of those cases of people who do a lot of brain guided. They don't get it right all the time either. So guided surgery for me is a bit like parking sensors on a car. And like most men, I think I'm a good driver, but like, my truck says otherwise. And I'm sure if I'd had some parking sensors, I would have known about the tree before I knew about the tree. So this was where we were sort of heading 25, 30 years ago. We would be going with these very dedicated guides. You need to have quite a lot of high clinical expertise because you need to know that to lift a flap if things went wrong. And we're putting the implants in. And, we'd go to these, and then you can even see here with this case, you can see where I've had to trim the edge of the carrier even to take the impression. But the result looks fine. And weirdly enough, when we look at the screw access hole, it's in the right place. And I was seeing this a lot, and this is something I talk about in my book about, for most patients, we've got an ideal location that we could put the implant. And for me, the ideal location is if I could pick it up with my fingers. It's not going to work. I think pick it up with my fingers and just put it somewhere, then that would be my ideal position. Now, my ideal position will be different for you or somebody else. I might favour my implants a bit deeper. You might favour them a bit more palatal, but everyone's got this position. And when I looked at my distribution curve, when I was placing these implants without guided surgery, it was far wider than when I started using guided surgery. I went from being mostly unhappy with my placements to mostly happy. And this is when I came up with this, and it's slightly cheeky, I know. When it looks slightly wrong, it's often right, and when it looks right, it's often slightly wrong. And I think this is because as a human being, we're so worried about getting it wrong. So we tend to, and this is why people quite often say, well, I'll use the guide to drill the osteotomy, but then I'll take it off and I'll finish it by hand. And that's the wrong thing to do, because you're going to default to safety. If you like your implants placed a bit deeper, you put them deeper. If you like them slightly palatal, you put them too palatal. That all comes with the caveat that if it looks wrong, it's often wrong. We're talking about when it's slightly wrong. And why is this important? I think we can all agree that when we put the implants in the wrong place, it usually ends up being a disaster for the patient and ultimately a disaster for us. So why guided surgery? This is what I get asked. And I'd flip it on its head and say, why not guided surgery? There's so many benefits for the dentist, for the patient, and for the laboratory. And I don't know about the rest of the world, but now in the UK, we've got several laboratories that are offering reduced costs for the crowns or reduced costs for the final restorations if you're using their planning services and using guides. So let's consider a case. And I'm going to show a few old cases because, maybe I'm just an old fart. But, these cases that you see on Instagram that, barely the stitches are out and they're claiming a huge success. For me, it's not a success unless it's been there for, really 20 years. But let's say, you've got a reasonable indication after maybe 10 years what you've done that's going to be successful. So hopeless premolar taken out, implant put in as an immediate. And you could look here and go, well, maybe that just looks a little bit too close to the molar. I thought you told me this guided surgery was good. But that's the thing. We're planning the screw hole exactly to, in this case, the middle of the fossa. And that means that sometimes it's not going to be, the implant's not going to be exactly in the middle of the ridge or exactly mesiodistally splitting it. It's going to be in the position it needs to be prosthetically. And you can date this case just from the old polyurethane models that were being used for it. And here you are, not the nicest result by today's standards, but here we've got one of the worst types of implants for guided surgery, and it's been placed despite being a difficult place to put an immediate implant and with the vital anatomy. So if we wheel forward, and look at a case like this chap was sent to me because his crown kept on coming off. It's no surprise, you'll see why. But I said to him, look, I can make you a crown that won't fall off. But we're going to have to deal with your gum disease and your periimplantitis. And so I made him a screw retained crown, and we sort of did some treatment, and he left moderately okay. And a few years later, he contacts me. He's an important guy. He's on the road, and he's like, that crown that you told me was loose is now loose. You told me it wouldn't come loose. And he was sort of joking, but he sort of wasn't. And I said, oh, well, if you can see a dentist, get an X-ray. So then he sent me this X-ray through, and I could go, aha, I don't think it's my crown that's loose. It's your implant. And it certainly was, because by the time he turned up, it was in his pocket, and he brought it with me. And this is the problem I see. So this implant's not put in straight, and it's not put in deep enough, and that's caused a problem in a patient that you can see has got lots of issues. So am I right to be worried about my case where the implant goes in a funny angle? I think I am. And this is the CT scan, because he wanted it replaced. And I looked at it and I was like, well, I'm not even going to accept the other one. If anything, that's worse placed, the premolar. So then we talked to him a little bit more about things like his grinding, and he said he didn't like the way his teeth looked and it's periodontal disease. So we then turned the patient from a case with a failed implant into he's having a full mouth reconstruction. We work on his gums, regenerate some bone, place a couple of bolts, prep him for a full mouth. And, we take him from basically being a bit of a dental cripple to having a nice, if slightly white smile. All my patients want white smiles, whether we think it's the right thing to do or not. And these principles are not hard to find. Got the ITI guides. You can look online. People love to post when other people have mistakes. And even our own patients. The patient here came for the 2-1 or upper left 1. It was a no-frills implant from us, but still guided. And then they decided we were too expensive, so they went somewhere else and ended up with the behemoth on the upper right one. And they only came back to see if there's anything I could do. And I was like, should have seen me in the first place. So this is a chap that we saw, I think, in I'm going to say 2010, but it might have been 2012. So median, we used slow drilling protocol. It's an old case, so we made the temporary on the day, and so just freeformed it. But you can see a week later, it's looking like it's healing nicely. 12 weeks later, we're taking the scan, and when we look at this case, we can just see the beautiful papillas, high implant stability, dated again by the old model and the old iTero scan. And here's the case being fitted. So yeah, 2012. And this is when he comes for review, I think. No, the point I wanted to make here is the patient also had a previous implant with me. And in those days, rather than an immediate, we took the tooth out, we threw the farm at it, took the tooth out, waited 6 to 8 weeks, did a bone graft, but a pig, put a cow, left him alone for another 12 weeks, did another surgery. So he'd been through the ringer. And what he said, I can remember still vividly, I could see why you wanted to do it as an immediate. Like, it was a lot easier for me, and it must have been a lot easier for us as well. And the flip side is too, a lot more profitable. Like, you spend a lot less time doing these cases if you do it this way. And this is when I reviewed him in 23, into 23. Unfortunately, this chap, he's passed on now. So, but this is the ultimate success. It's been a restoration or 2 implant restorations that have survived the patient. And when I look at it, I do it a little bit differently. Obviously, no soft tissue graft with this case, but still the papillas look fantastic. And if you look at this case here and you compare the two implants, just look at the amount of bone that we maintained around it. And this is with, a less ideal emergence profile than what we know now. We've got different sort of components that we can use that make such a big difference. And you can see the bone, the difference in the bone profile, even though same implant, same company, just different approach. So I'm slow on the uptake, but I'm not that slow. And when patients kept on saying the same thing to me, I started feeling like I'm really onto a good thing with this immediates. And the flip side of that was I really wanted to do them with guided surgery. But the one problem was that, these immediates for single teeth, they were adding a lot of extra cost to the case. So, there was a famous prosthodontist who used to say, if your patients knew what you knew, they would want what you would want. So I was pretty good at getting patients to have the work I wanted. But I had this lady come in, and this was an old case. In fact, some of you will recognize how old it is just from this. So she had quite a significant defect, and she needed a couple of implants. So this is even co-diagnostics version 8 when we're using the Goni-X. This is an old case. So it shows you that we're doing these things for a long time. And I took my scan, and I'm like, well, I need to get these implants in exactly the right place. So even though the patient wouldn't pay for the guided surgery, I did the guided surgery for free. And that allowed me to put the implants in, do the bone graft, and get, a significant sort of amount of volume at the same time. In this case, it stood the test of time as well. Do it completely differently nowadays, but the result's a nice result, and that was 2012, and the patient's still going strong. I hear some of you probably thinking, yeah, that's great for small cases, but what do we do when we get a little bit bigger? Well, the great thing with guided surgery is you can just mix and match. It's, once you understand the single tooth, you can do all sorts of things, and in this case, for instance, we've got a combination of where we've done a tooth-supported guide, a tissue-supported guide. We've used fixation pins. Some of these implants will be immediates. Some of them we're going to lift the flap for. And this is going to allow us to do what we call a long-term provisional. So we do an intraoral welding situation, and then we take a PMMA shell and put it over the top. And you just couldn't do this without guided surgery. So you need to be able to put the implants in the right place to leave enough room to weld the framework in the mouth, and then still be able to pick it up. And actually, I'm just going to go back there to make a point. So with this, I talked about ideal locations, and you could argue some of them could be slightly in a better position. Maybe the canine could be in a slightly better position. But generally, when I look at it, this is a case where I'm like, do you know what? If I was to pick the implants up and put them in the perfect place, they wouldn't be far from here. So I think that that's a massive power of what we're doing. Then we've got a situation where we do the upper, so it's an immediate load on the day, put a lower in, which we restore conventionally. But the nice thing for this patient is that, and this was done in 2025, is this is genuine teeth in a day. So that they come in, have their teeth out, the implants go in, and we made them a long-term provisional. And we told this patient that she should expect to get 18 months to 3 years out of it. And this is the patient in 2022. Now, I will catch up with her and get a final full contour zirconia restoration out of her at some stage. But she's like, well, why would I change it, And this is the power of putting the implants in the right place. Some of you might have heard me talk about pre-mortem before. So for me, one of the massive things we can leverage with guided surgery is when we do the virtual surgery, it's a bit like the bobsled guy at the top of the run, going through, envisioning all of the turns he's going to make, where he's going to break, how high he's going to go up on the bank, etc. And pre-mortem, not post-mortem, is what they call an analysis of potential failure before it happens. So if you're pre-armed, you're pre-warned, and hopefully I'll show you a case that we planned together, and that'll sort of illustrate what I'm talking about. This is a lady who was referred to me by another specialist. That always gets your attention. You know, if somebody who does what you do doesn't want to do it, and she was a very fussy lady. So the first thing we do, and this is our pre-mortem, is that we make her less fussy by making her wear some braces. We then extrude this tooth that takes the soft tissue with us. And then because we know this patient's got a very fine threshold for things not being right, I'm not going to use one guide. I'm going to use multiple guides. So effectively, 2 pilot guides, 2.2, 2.8, and then I'm going to have my guide that's the final diameter of the sleeve, so I can place my implant through the guide. We then have the temporary. We start with the pilot, 2.2, go through a series, and these days I do this slightly differently now, but there was a dehiscence, so we ended up having to lift a flap. We can put the implant in. I'm not going to labour the case too much, but make sure that the implant's at the right distance below the proposed gingiva of the final restoration, or proposed final restoration. Suture it up, and this is the result when we go to take the final impression. And to be perfectly honest, that's not even a soft tissue graft, so we're pretty happy with that. I don't mess around with any of these custom impression coping, so I just take the temporary off quickly and scan it, and that allows for the technician to make a reasonable crown. We had planned for an enameloplasty. This patient still haunts me. I still see her and I still say, can I just slice a little bit off that tooth? It make my photos better. But she wouldn't. And that's the power of what we did. We took a really tricky patient that had massive reservations about the treatment and how it may look, with an ultra high smile line, and we give her something that looks very natural. So this patient wasn't actually referred by another dentist. I'd done some work on her dad, and the dad wasn't happy with what had sort of happened. Patient had some orthodontics and some sort of Mirrorlands, etc. And he's like, well, couldn't you do some implants for her? So I get her in and I have a look, and obviously she's going to need more orthodontics because what was done wasn't good enough. She's a very precious young girl, so I could, within about 48 hours, she wanted the braces off, but I'm pretty miserable, so I made sure that she kept them on. And then at the end of it, she's got virtually no bone, so we then, but I want to put my implants in, as I've already said. I want to do it in one surgery, so there's not much bone on that side, and just a little bit better on the other. And for the clinicians watching, you'll realize that these implants this is not just a dehiscence. These implants are in the wind. But the one thing is, by using guides, we managed to get them in the right place, and this is where you'd struggle so much freehanding a case like this. Throw a huge chunk of bone at it, and we can take the patient from here to here. The patient declined soft tissue grafting, otherwise this would have been an outstanding result. Pilot guides, there are some room for pilot guides. So this is a case where it was going to go legal. Orthodontist had debonded, and the patient couldn't have implants because nobody would treat them because of the spaces. And this is a pilot guide because there's no room for anything apart from a pilot guide. But we still managed, by using guided surgery, to get these implants in. That's on the day of fit. This is what it looks like a week later. And you can see, even though we managed to get the implants in, and the implant on the left-hand side, there's virtually no bone. It looks worse than it is because it's actually positioned slightly in front of the roots. But you just wouldn't be able to freehand a case like that. You need to use guided surgery to do these things predictably. But I think we can look at this and go from where the screw holes are, that this is an acceptable result, and still restoratively driven. Nice soft tissue result, breaking all the rules, of course. And this is the patient in 2023, and I have reviewed her subsequently, so the presentation's long as it is, so I didn't want to keep on putting more things in. So why might you want to know how to plan your own cases? Well, in the old days you had to, because things like this would happen, like when we were using the co-diagnostics version 8, you needed to have the scans taken with fiducial markers that then became the guides. And if you didn't pick up a mistake like this would be made, then you could have been in serious trouble. So that was one of the main reasons for bringing the CBCT scanning in-house at that time. This is a case more recently, just show, we're not going to just show old cases. So this guy turned up. He was a dirty old man, so to speak, and we followed all of the principles for implant placement, and I really like this. This is another thing, about guided surgery, that when you lift a flap, it's really easy to lose where your position is. If you don't lift a flap, it's hard to know exactly where you are as well. So with our planning, we can plan, and in this case I've got a 4mm abutment, and I'm planning exactly to the proposed margin of the final restoration. And I'm not going to apologize for banging on about this, because I am going to bang on about it, but it's something most people get wrong. And you can even see we finished the case, and I think we've improved the gum around the implant crown. There's even more gum than what he started with, and it's an acceptable result. But this is this probably shows it a little bit better. This is the great thing with guided. Like, I've taken this patient from being somebody who wasn't interested in their mouth to then wanting me to do treatment that they hadn't even really thought about. And then in this case, there's pathology that we can identify, which we can remove because we use a guide and we know what we're doing. I'm not 100% happy when I look at this. Like, I've gone on a diagonal. I tend to now go 4mm, and I'll go straight up. So you can see that this implant's actually a little bit shallower than where I should be. But the fine purple line is where the gum is, and the blue line's where I want it. So the planning is to where I want it in an ideal world. And this is critical for getting the best aesthetic results. So here you go. I've removed the pathology. Implant goes in, roll flap, and then we restore the patient. And actually, subsequently to this, the patient's now had implants on the other side as well. But just don't want to keep going. When I say keep going, I'll keep going, but I don't want to keep adding more photos to the presentation. So my son is a professional rugby player, and he's out in America, and he's got a saying, abs are made in the kitchen. And I'm more of a cake guy. And the reason that, if you want to make a cake, you need a recipe. And when Snappy talked to me about discussing what I did, what he was really saying is, can I just run through with you guys what my how I use co-diagnostics in my day-to-day work. So, and we use it every day. So I'm not going to label what an examination is, but like, what happens is when I do the examination, I do have a big screen TV at the end of the room, so I can go through in detail, and I show the patients how we're going to use this technology to to treat them. Then they hopefully go and book the appointment, and then what we do is a workup appointment. Now, I'm not going to go through this in too much detail, but what we talk about in reference to co-diagnostics is I have one of my assistants, a dental therapist, takes the CBCT. She would then send the CBCT off for reporting, which is something that needs to be done in the UK. It's a necessary evil. Take new intraoral scans if necessary, and quite often they're necessary because an example, and I'm going to show you, is that I want the palate. I want if it's a maxilla, I want lots of soft tissue for when I'm matching my data set. We might need further information. And what I do is they then, the therapist puts it all, because this is done when I'm seeing somebody else, puts it all together, puts it through the AI with co-diagnostics, and then I do some basic planning with the patient. And that allows me to identify any pressure points there might be in the treatment. And I'm going to show you it's not a copy of a patient conversation because I want to be able to tell you what I'm doing. But yeah, I'm going to show you how we do that. Just bears mentioning at this stage that, to get the best results, you need to be taking the best records. Intraoral scans, weirdly, most intraoral scans will take a good scan. What your problem is more bad three-dimensional scans, and the better the machine you can use, the ideal. But it doesn't really matter. A good CBC without good technique taking the scans is still not going to be giving you good results. So you can see here, this is the way we used to do it, and we don't normally use a radiographic marker. But the great thing about guided surgery as well is that if you get a failed implant and you've got a prosthesis, quite often, if you're careful with how you plan, you can still use the existing prosthesis. So here's a big cotton roll holding the gums out of the way. And you can see that when we use this is going to tongue down and it's going to give us all soft tissue. So the data match is going to be so simple in this case. I've now moved to using an obfuscate. Now, this is for the eagle-eyed amongst you, it's a modular case, but it's the same thing. The obfuscate shows you how, if you put this in when the patient's having the CT scan, how much it reflects the soft tissues, which will give you a better scan. And for your real nerds amongst you, I make my team then take the window level and the window width and then put that into the grayscale and co-diagnostics, because I like my co-diagnostics to look exactly like the stuff that comes out of the Marita. So, I thought about trying to do a lot of photos and trying to explain it, but I just thought it might be easy just to show on video. So, Stephanie, if we don't have any sound, let me know, but hopefully this should work. Right, so I'm quite lucky because my team pretty much give me everything. Sorry, can you hear that? Work up. So
yes, I can hear it.
X-ray, intraoral scans, the photos, all of the records I need, and then the patient, and then I have my therapist go through everything to do with the surgery, check the medical history, all of the things that I've just shown you in the previous slide. And then they upload everything, including putting it through the AI. So let's just have a look here. So if you have a look at the AI assistant, what I would do here is I would delete the bits I don't want. I normally I just check the patient coordination system if it's right. I normally set the panoramic curve myself just because I prefer it. And scan alignment, this is pretty good. But one thing I'd say about the scan alignment is that a lot of people don't understand that this is the most important thing in the guided surgery. Yeah, and with this particular patient, it's a relatively straightforward case because she's got there's no scatter, but you can see that we've taken the scan in such a way reflecting the lips and cheeks. We've got it's an upper arch, so we've got the patient to keep their tongue low, so we can just check that the soft tissue matching is as good as possible. And one of the things that people don't really understand is that realistically, enamel is hard, so you do get some artifact from it. And if I was to make an argument looking at this, I probably would just sit there and say that this needs to go up and slightly. I always had it the wrong way. Because I want my soft tissue to match perfectly, not necessarily the hard tissue. So when I have a look, the soft tissue should look fantastic and all. And I want my almost a ghost image, the enamel. I don't mind the enamel to be slightly wider than my STL. So anyway, so that's I'm just going to cancel that because I've done the case anyway. So then what can I show you? So it would come in and we would have the soft tissue. Then the other thing that we would tend to do is we would then have the planning for the patient. So let's put an implant in, and then you can see here I'd be doing some rudimentary planning when the patient's here, just to see if there's any pressure points in the surgery. Now, I know because I've already planned this, that this is a pretty tricky case. And when I was looking at it initially, I was like in two minds whether we could do this as place the implant, do the graft at the same time, or whether this would be best as a two-stage grafted procedure. So, so then I get a chance to present it to the patient. And when I present it to the patient, I present it on a big screen, and then I can get rid of the model, and they can see. I normally put the teeth on, so when I'm discussing it with the patient, they can see that there's a big through defect. They can see that there's going to be a bone graft. They can understand things like, we're going to take the soft tissue, and then I've even drawn on here the nerve and the blood vessels, saying that obviously there's a risk of a bleed. You get quite thin tissue here, and that will sort of help with consent. So that's what I do for my initial workup. Also when I see the patient, and then what my whole philosophy stems around is getting a proper diagnostic wax up, an anatomically correct diagnostic wax up. So this is an example. And keep that. So trying to get rid of the AI, not the. So this is, you can see the defect. Check on that. It's quite significant. You see I've got a sleeveless plan here. We'll go into that later on. So my whole thing is to have a mock-up. So it's the mock-up there, anatomically correct for this patient. But then I want adjusted tissue. So I want the mock-up on the adjusted tissue. So when I do the planning, I can plan my vertical correctly, and I'm planning to where the proposed best situation is, and I'll just graft it, hard and soft tissue. And obviously for multiple implants, it's just the same thing. We'll just do more of it. So then, obviously, I write a lab docket, and then I've just got a template to make that easy. I'm going to video that, but I'm going to play it. And then what we do is that we then get that information back. And on Wednesdays, I have a day where I do my letters and I do preparation for courses, or so I've got some time set aside for planning. A real tip, and I got this from the guys at Chemet's, is if you're using co-diagnostics, get yourself a 3D mouse. It just makes things absolutely so much easier. If you're a clinician, don't just get the planning and just not think about it. Like, in this case, it's an immediate, but I want to know where I expect to go into the bone. So I not only plan for the implant I'm placing, but then I'll take a note of how long I would expect the first drill to have to be before I start entering into the platal surface of the socket. Because if you're getting something different from what you planned, you need to sort of go back and have a look and see if your guide's fitting, or maybe your planning wasn't right, or and you can see here, this is just it blown up. So even if I'm putting in a 16 millimeter implant, I'm still want to know when I should expect to start going through the cortices, because if I'm not, or if I'm slipping, I might have to go in freehand to just open up a little landing zone in that area. So I've just got another video, so it's going to be a little bit video heavy, showing how I would then take what I did at the workup appointment, and that's done with the patient sitting there in the chair, so it's on their time, and how quickly, because this takes a bit longer because I'm explaining it to you, but you can just see how quickly we can really generate the planning. So this patient's been seen for their initial workup, and now, just let me know if you can't hear it, Stephen. Got the wax up back from the lab, so we're ready to proceed.
We can hear.
So we just go to the wax up, and let's put the mock-up on the model. Split one. So just for clarification, this is the same case. So it just effectively, it's just going to copy the alignment of the previously aligned scan. Good. And then we can just add the other information. So we want the adjusted tissue. We got it right. So we can see here the increase in volume of the tissue. Likewise here. No. Right, and then the last one is mock-up on adjust tissue. So you don't really need the combination one. You can just use both, but I just use it. The more information, the better, so to speak. Now, so what we've got here is we've got the planning that we did initially looking at the situation. So you could see that if we didn't get a wax up, we could potentially be in the wrong place by quite some way. Now, in this situation, I might be looking at using an angled abutment. We'll see how this all looks when I put it together. So let's go this. And just tissue. I'm going to keep that maxilla. Hopefully that will show you the best. I didn't think. Okay, so when we look at that, actually, my guess for where I was going to put the implant, not too bad. So what I tend to do now is I'll have a look at this. I'll put a sleeve on. It's always helpful to have a sleeve. I'm going to go with this to start with. And one of the reasons the sleeve's quite useful to put on is sometimes it can help you with orientating the depth. And let's so let's go final fractionally. I always go the wrong way and look actually why. It probably is intuitive. And probably just me not being intuitive. Yeah, so that would look all right. So then what I've got to do is I've got to then scroll through, make sure that I'm not going to end up drilling into any roots. And that's looking pretty good. Then I usually will put on an abutment. Now, with this particular one, it's, I'm going to put a 4.5 millimeter magenta coat on it, just not because it's what I want to use, but this is going to help me work out height-wise where I want it to be. So my proposed tissue is a little bit more superior. And this is, we can go to localizer or centralizer or whatever, and you can see, I know that the sleeve is 4.5 millimeters below where I want to be. So then I'm going to effectively come out a little bit. So. Okay, and then I'm just using the screen here to see if I'm roughly where I want to be. So it'll quickly reverse, but you can see the line here. I'm pretty much, I just need to come down maybe, and then I'm going to put a hole 5. So I just don't want to be quite that deep. Now, once I've done that, you can see, I get rid of this. We're in the right place. We've got our sleeve. We've got, I'm going to get rid of this now and change it for different abutment. So let's go for, I'm not sure that I would actually immediately load this, but let's say we and you have to get the tissue and mock it. Just that.
Hi.
And then when we look at this, we can see that, like, you know, a lot of the time, if you were to be looking at a CT scan with these sort of defects, or looking like this, that you might not actually think that you could get an implant in, but by using the power of planning, and also the power of using wax up, you can see that, like, this is going to be slightly below where we want to be, just a tissue. And then mock-up on adjusted tissue. So this is my point. As you can see that I know that the sleeve is about 4.5, and it looks to me like that's just going to be 4.5. So I'm actually even in this situation. I'm going to come and I'm going to get final alignment and I'm going to drop it down another 0.5. And then I know that this is going to be 4. I'm going to do a bone graft. I'm not going to immediately load this. But I'm absolutely confident that I will be able to get this implant in place. So the nice thing about using the planning in this way is that I'm spending a bit of time doing this, but it's going to mean when I go to the surgery, it just saves me so much time. And, I look back at the video of the surgery, and I think the whole time doing the osteotomy was about sort of 3 minutes. And when you see, we've got a technique that we use to get the implant in the right place that makes it more complicated than a lot of other people would do anyway. So guide design is a thorny issue. I tend to design my guides differently than a lot of other people. Right, so we can plan this now. Now, in this particular case, I'm just going to use the upper guide. I want to make it so insertion favours the guide as much as anything. So I get a nice amount of material around the sleeve. So I'll make it a little bit bigger. In this case, I don't like to remove the sleeve, so I'm going to make it like 5. So that's going to make it a little bit thicker. To make it so nice and sturdy on these teeth. And then this had to come across with some cross stabilization. And I'm probably going to use some navigation. So I just want to leave a bit of space so I can put my navigation marker in there. I didn't need quite as much as that, but I was worried I could also put some sort of palatal support on here. So maybe what? Yeah, get there in the end. Some inspection windows. So what about get in there? I can use a burr extender, so I don't need to worry too much about carrying it much more than that. Good. So let's do. See. Just keep going down.
Today, pet light.
Yeah,
That's a bit of fair.
Here's a slightly bigger one just to trim that a little bit. Then add another inspection window. Is it? And add an inspection window. Neat. Engrave. Use the rotation for sleeves. I could penis running out of. Okay, so there we have a completed guide. See, I'm running out of memory, that's why it's not liking this particularly much. But you can see here, and likewise, I've still got enough room to put my marker in this area. If not, I could add, I can actually add primitive and subtract it from the guide as well. So that's an example of a guide. For the eagle-eyed amongst you, you'll see that we're going sleeveless. So it's designed with a custom sleeve. When Snappy asked me to talk about that, there's just so many cool things in co-diagnostics that I just couldn't not mention the mesh editor. And that's really handy for, like, we can extract the teeth, but at the same time we can then adjust the mesh, when we've got deeply placed implants like this. And then we can use the power of the AI segmentation, and we can merge things together. And this is something I do a lot when I'm doing complex bone grafts, because I can print the models and then I can do the stuff outside the mouth. So this is this case, and sorry, I know I'm dragging on a little bit, but I think it's worth showing the case. It's what we call a knife edge ridge. Now, really difficult to take a conventional guide and get into that where you want. So what we've done is we've taken a guide that we've designed. You can actually see I have used a primitive to cut a little bit of space out for the navigation, but we didn't use it in the end because the patient had a lot of bonding and I was worried about breaking it off. So what we've done is we've used the same pinhole that you'd use for a fixation pin. We then drill that, and you can see by using a smaller drill, I think it's a 1.3, we can open up the pilot channel. Then we can go in and open up the osteotomy. Then we can go for form drills. In this case, we even used an osteotome inside the guide, and you can see, looking at that, how well the guide's fitting. It's the actual fit of these guides is fantastic. So when people tell me guides don't fit, I wonder what they're doing. And not the best videos, but just to show you sort of, like I said, like I might spend time on my planning, but that allows me to get my pinhole or my pilot hole, if you like, in the right place. And then that allows us to get the implant exactly where we want it as well. And the nice thing about that is when I look back at taking the videos out of because we videoed most of the surgeries we do, the actual time putting in the implants, even though this is quite a complex one where we've done a pilot hole first and then osteotomy, the whole thing was about 5 or 6 minutes. There's the implant for, if you can remember, there was quite a substantial amount of implant in the breeze with the planning. So we're seeing what we expect, bit of autogenous bone there. We just leave that. Then I come to my models that I've printed. I always take one without the teeth because it's easier to shape the membranes on that. And this is a bit of cortical bone, curved cortical bone. Do a bone graft. You can see that we've built everything up quite substantially. Then we've got some membranes that go over the top, and then we've released the tissue so we can get a really good tension-free closure, which is critical for these cases. And you can see there's no blanching, there's no bleeding. There's soft tissue graft in there as well, and that's the temporary. So technology's moved on, looks better and better and better. Are we going to be replaced by robots? I haven't seen who else is speaking today. Maybe somebody thinks we might be, but I'm not feeling that we are. Navigation's an interesting tool. We use it in combination with guides, not often as an exception to guides. There are sometimes when it works really well when you can't use a guide, but my true feeling about it is that it's something that benefits from being used with the guide, certainly the way I tend to do my treatment. Augmented reality, here's me with Snappy a few years back, sort of looking at his cool toys. I've already sort of mentioned, from a legal point of view, I think guided just puts us in such a better position, which is incredibly important in the UK. And I hope this presentation's helped illustrate that modern guided implant surgery and digital implant workflows can help to deliver even optimal function and aesthetic patient outcomes, streamline implant treatment times, increase predictability, and keep us safe. I'm just going to skip that. I had a video, but I know I'm running a little bit long. So it was just a video of surgery. So you've all seen that before. He who fails to plan is planning to fail. And I also like this quote from the other side of the ditch, which I think just absolutely nails down guided surgery. Give me 6 hours to chop down a tree and I'll spend the first 4 sharpening the axe. It's curtains. That's what it is. So it's all about understanding the plan and carrying it out accurately, even if others are slow to catch along.
Is everything. I think it's the future, it's the now, it's if you're not in it, it's time. Get in it because you really need to get involved.
Thanks very much for your attention, and if happy to take some questions. And if anybody wants to contact me about anything that I've said, then just feel free to reach out on the socials or hit me up on email, and I'm always happy to help.
All right. Thank you very much, Nick.
Sorry, I ran a bit over, but the technical thing sort of threw me.
It's not an issue. We have some time left. So there should already be at least one question for you in the question window, if you can see that.
You're going to have to help me with it.
Okay, in the upper left corner, there's a little
question mark.
Question mark. If you click on that, you should see the questions that have been assigned to you. This one. I think somebody wanted to see a particular slide again.
Oh, okay. I'd like to see the following slide, if possible, first appointment checklist video. We can do that.
All right. If anybody else would like to ask Nick a question, you can type the question into the question box now.
Yeah, so for my workup appointment, this is something in the UK. It's very tricky to take CT scans without justification. So we can't take the CT scan or CBCT scan just because the patient rings up and says that they want an implant. So some people will turn up with a scan, which then means that, like, you know, we can run it through. We normally use DiagnoCat, which is an AI software, because even though legally you're meant to have a report, most people don't get reports. You know, for us, we get reports because we're a referral center. So lots of people refer to us for CBCTs, and they changed the rules a few years back. So it used to be we could get people to say that they would sign a piece of paper saying that they would do their own reports. But now the vicarious liability is on the people taking the x-rays, which is us. So this may not be exactly how some people would do it in other countries. In America, you know, seem to get a CT scan, you know, when you get a toothbrush, you know, it's like it's a different sort of philosophy. And I'm not saying this is necessarily right, but this is how it works. So we check the medical history and the particular things that we're always looking for. You know, stuff that maybe they haven't mentioned the first time around. So they tend to remember things like, you know, what they're taking every day as a medication, but particularly anti-resorbative treatments, like if they're on 6-monthly injections or 3-monthly injections. Check that the medical history hasn't changed. We also check, we're going to give you some antibiotics probably, just make sure that they're not allergic. We do a blood pressure at this stage, because if we do a blood pressure on the day of surgery and it's through the roof, you don't really know what the story is. The glucose test is something we've done because we've had a few failures on people who've ended up being diabetic, and one of them in particular, I tried to get him to get a test, and he said that I was picking on him because he was overweight. And so now we just do the glucose test for everybody, so we can sit there and go, hey, this is not, we do it routinely. So no glucose tests, no go. Checking veins if the patient's having IV, there's nothing worse than my lines normally get put in by somebody else, but they come and get me if it's difficult. So I want to have a look, because if I go, this is a difficult case, I want to have first crack at the best veins rather than one of my team members coming back and I go down there and the patient's had 20 attempts. So the CBCT is taken by my therapist, and that's done on the same day. She will send that off for reporting. We've got that quite streamlined. The CBCT then goes into Diagnocat, which is an AI software. So one of the reasons we like doing that is that I want to start getting the patient aware if there's something else in there. Say, for instance, there's sinus pathology, or say that there's some root canal treatment that needs to be done. And in those cases, I'll normally say, look, we're going to send this off for reporting by the maxillofacial radiographer. He might suggest this and this because the AI is suggesting this. And the weird thing is, since we started using AI and since, we refer these things, patients accept it a lot better. They accept it a lot better when it seems just like the AI is telling them they need to have something done. Whereas if you find it, it's, oh man, you're always finding these things. I talked about the intraoral scans, the further records, things that we would do for more complex cases. We take videos for full arch cases as much because we want to check we've got a record of what the patient sounds like. We also take facial scans, so that's a 3D facial scan that then gets put into the software. And as long as you reduce the mesh size, you can do that with co-diagnostics. We take mod jaw, which is the jaw movement information, and sometimes we might take further bite records. The most important thing is to do some basic planning with the patient, because then if you do it while they're sitting in the chair, then it's on their time, not your time. And then you can sort of show them the pressure points in the treatment. So therefore, they can't sit there and say, and then I can put on my records, I did some planning, and then that's another clinical record that we've discussed the stuff with the patient. And then once again, right at the end, we discuss the treatment again. Because if you've pointed out, say, a tooth needs to come out, the patient might go, well, actually, could you do that at the same time? Could I have 2 implants rather than 1? Or say, for instance, you'd given them options, like you're doing the full upper arch, and then they decide suddenly that they're going to do the lower arch at the same time. So it's always worth making sure that you sort of cover over all aspects of the potential treatment in this appointment. And how long would it take me normally to do all of this? It's 15, 20 minutes max.
All right. We have one more question.
Certainly.
Question box, you should see it. Paper one. Also, some people that said greetings and thank yous.
Oh, that's good. Now let me see. I took your advice, Stephanie, and set up 3 monitors, and I'm completely confused. Yeah.
Okay, Gojo, if you go to the question box, it should be the first question. If you click on that, you can see the whole question.
Is it the from Belgium, or?
Or there's someone else, Ali Temara, asked the question, is there a way to estimate the amount of bone needed for bone graft on?
Oh, yeah, no, it's just popped up there now, so.
Oh, okay.
Can I just open those slips there? is there a way to estimate the bone needed for a bone graft on co-diagnostics? The answer is yes. There is a feature that you can use for augmentations. It seems to work best for sinus augmentations, although sometimes you need to use the mesh editor to repair the model because it won't. If there's any holes in the scan, which sometimes you get in the maxilla, it's a little bit more difficult. But you know, I'm a more happy nowadays. Just I've got in-house 3D printing, so and to be fair, like getting something printed is not the hassle it used to be. So, if you've got co-diagnostics or your lab's got co-diagnostics, you just get them to export the merged model, so that you take the AI model with the teeth and the AI model without the teeth, merge it together, which is a one-click process, and then you go to export virtual planning, export that as an STL, and then you can print it. And that's more the way I prefer to go with my volumes for bone grafting. And do you know what? You can, if I'm doing a PTFE case, like a vertical, I'll print it, and then I'll cut the membrane before surgery, and then I just re-sterilize it, you know. So I don't even need to do that as part of this. I just take it out. It's pre-cut. I know it's going to fit because I've done it on my sterilized model. And how do we sterilize the model? Is a good question, because somebody might say that is we put them in medical alcohol for 10 minutes and ultrasonic, and then after that we put them in sterile for 5 minutes, 3 minutes, whatever, in the ultrasonic, and then take it out and use it.
All right. I think that's it. No more questions? Unless, this thing, something just popped up. Yes. Let's see another one.
Can
you see the question by Jim?
About the zero relief,
Yeah.
Is it?
Maybe you can read it so the other people can know how to start.
Oh, you'd have to raise a ticket for that. The relief can be set. Like, you know, I only tend to do it a zero relief if it's a full arch and we're going on the soft tissue. So normally I'm going to put a bit of offset in there. And, you know, it's a bit of a dark art, I'd say, when it comes to that, Jim, is, yeah, if you've got long teeth and they've got periodontal disease, you might need a little bit more relief than if you've got short teeth and sort of little barrely, tubby teeth, you know. And in that case, I might give it 0.5 relief. If you've got perio teeth, probably more like 0.1. Yeah, so I don't think there is the ability to do selective retention or selective relief, but that would be a question for one of the technicians, probably, rather than me. And all I can say is that the great thing about co-diagnostics is that, you know, if you're not 100% sure, just contact the guys at support and ask them, because they'll either say, yeah, we can help you with that. And so a lot of the features that I've found aren't because I've found them. I've been asking a question and then somebody's gone, yeah, you know, that's already in there. So it could be there, and I don't know.
Yeah, we'll be sure to let the responsible people know about this question.
Oh, sorry, I lost you there for a sec.
Oh, I just said we'll let the people who are in charge know about it.
Yeah, and Stephanie's very she's very diplomatic as well, so you can always let her ask for you.
All right. Yeah, I think that's it. No more questions so
Well,
far?
can I just say thanks to everybody for listening? And I see there's a few people from around the world. So, greetings from nearly sunny UK and wishing you a lovely weekend.
All right. Thank you so much, Nick. Yeah, I think everyone enjoyed it. And bye-bye. Peace.
Yeah, and as I said, if anyone's got any questions that they don't want to ask here, just you can either contact the guys at Code Diagnostics. They've got my details, and they can send something through, or just hit me up on socials. Or always happy to have a discussion about anything to do with implants and in particular guided surgery. So thanks very much.
Thank you. Goodbye.